Well, it's 9 o'clock. Good morning. Right on the button. 9:01. A few coffees are still coming in with a few people who've just entered the building. We appreciate all you returning for the second day of our summit. And we've got another jam-packed day and a jam-packed morning with a couple of great sessions that will precede our first break of the day. And lunch is coming in again. Same place. It'll be a little earlier today. So and they've promised a little variety in the menu for noon, but I don't know how they're going to improve on yesterday. It was fantastic. And you've been fantastic too. And so has the still fairly new, to me anyway, Health Commissioner of Onondaga County. Her name is Dr. Katie Anderson. She's going to kick off our presentation this morning about the priority that Lyme and other tick-borne illnesses have for public health, especially right here, right now in our host county of Onondaga. Ladies and gentlemen, please welcome Dr. Katie Anderson.
Good morning, everybody. Nice to be with you all. And my goal here is going to be relatively focused and efficient because I'm standing between you and an amazing patient panel, which last year when I attended the Lyme Summit, it was one of the most impactful things that stayed with me, seeing patients and just going about my life as a resident of a very Lyme endemic area. So my background is as a clinician as well as an epidemiologist. And yesterday we had some great data presented on local data, local trends. And so I'm not going to really focus in on that too much because Dr. White from the New York State Department of Health did such a great job. But I thought instead I would back up and think about what are the big gaps that we have currently in terms of tick-borne disease and what should our priorities be locally so that we're meeting the public health needs of our folks. Let's see. Thank you. Briefly, we've seen variations on this slide yesterday, but tick-borne diseases are on the rise. We're seeing here in the United States from 2001 to 2019, the relatively rapid rise of a variety of tick-borne diseases, the emergence of new diseases, and the increase across the board in terms of the diseases that are in circulation. There's a couple of reasons for this. I apologize, this slide is relatively small, but what we're looking at here is trends in deforestation and then reforestation. So tick-borne diseases are on the rise for a wide variety of reasons, but partly because the habitats in which they thrive with kind of fringe habitats, mice, deer, forests, woods, kind of close to human habitations have been increasing. So there was deforestation and then some kind of fragmented reforestation. And this is one of my favorite slides in epidemiology, which is showing the dramatic movement of people. So going back to 1850 to post 2000, the number of days it used to take to circumnavigate the globe in red. So it used to take you a year to get all the way around the globe by ship, by foot, by whatever means, and now it can take you 24 hours. And then in the green is the exponential rise in the human population on Earth. So if you think about it, we're more connected than we've ever been. And not just with tick-borne disease, but with COVID, with all these other infectious disease threats we're seeing, we're connected in terms of the pathogens that we're at risk for as well. And so we may see new tick-borne diseases. We have seen new tick-borne diseases, and this will likely continue. And it's possible that the threat of tick-borne diseases only stands to worsen. So here we're looking back at the last 50 years, but the climate change that we've seen, which is very impactful for vector-borne disease. It's impactful because it changes the habitats that these vectors can live in. Some of them need certain temperature ranges, and they're often, for example, in the northern United States and Canada, we have had some protection from some vectors because of our winters and the cold. But with global warming, that increases the northern range that these vectors can live in, and it also may increase the period of time that they can be transmitting throughout the year. So this has been a threat and has been likely a factor, and it will continue to be. And as we heard about from multiple presenters yesterday, there are problematic and numerous gaps in terms of what we know about tick-borne diseases, TBD here. So for example, we heard about how with respect to diagnostics, we don't have readily available tests that perform well in terms of detecting the bacteria in people's blood or detecting it in their body. So we rely on serology tests or looking for antibodies, but we know that when people are first coming in, when we really want to capture them and give them a good chance of recovery, their antibody test may be negative. So with respect to diagnostics, There are big gaps and big opportunities there that would make a big difference in patient outcomes. We heard yesterday about some gaps in terms of adequate and effective treatment for Lyme disease. So it tends to work relatively well, but not 100% if you catch people early. But as the disease progresses on to later manifestations, you need longer treatment and it may be less effective. We also have big gaps, as we heard yesterday, in terms of how we treat the really debilitating late manifestations of Lyme, like post-treatment Lyme disease and of course chronic Lyme as well. In terms of prevention, I should be clicking through here, excuse me. In terms of prevention, what can we do to minimize tick populations? There's some exciting technology that's being developed both for mosquitoes and for ticks in terms of how we could try to impact and disrupt both their ability to reproduce as well as their ability to transmit, but those have a way to go. And we still are waiting for the emergence of an effective human Lyme vaccine, as we heard about yesterday from Dr. Polino. In terms of pathogenesis, so understanding what are the factors that make somebody more likely to become very sick from Lyme or to have difficulty responding to treatment or recovering, as we heard about from Dr. Embers yesterday. There's a lot of variability. We don't know what the pathogenesis of post-treatment Lyme disease is, although there's some exciting work that's coming out in terms of metabolomics, other types of clinical signatures that may track with post-treatment Lyme disease. But we still don't really understand why it happens, which is fundamental for understanding how we prevent it. And then finally, my background, so I work in community health now, but I've worked in global health for a long time. And tick-borne disease globally is likely a major problem that is vastly understudied, which limits clinicians' ability to even have something in their mind when they see a patient, much less treat them with treatments that might be readily available, for example, doxycycline. And that also puts us up at increased risk for future threats that are not even on anybody's radar yet. So there's lots of gaps. And some of these gaps have persisted. This is a really nice paper that Dr. Embers was an author on, looking at current gaps in Lyme disease. And here we're looking at the amount of NIH funding that has gone for different diseases. I'll caveat this in saying that some of these listed here are global disease threats, and we're looking at US reported cases. But I'll draw your attention to the final column on the right, where we're looking at how much NIH funding is allotted per case in the United States. And you can see that if we look at what the estimated burden is, the extrapolated burden of Lyme disease, it's about $63 per estimated case, as compared to something like West Nile virus, which is about $13,000 invested by the NIH per case. And that's in 2018. So it's been underfunded, which contributes to these gaps. Thankfully, this has been trending up somewhat. We can see a doubling in terms of NIH awards that were given, and about a doubling of NIH funds that have been dedicated to research, specifically to Lyme disease in this case. And recently, in July of this year, the NIH did announce 2 large awards that were granted to research post-treatment Lyme disease syndrome research, which is very promising and something that we definitely need to understand better. So when I think about the 2 main things that I think we need to double down on while we're waiting for the research to advance, while we're waiting for these new studies on PTLD to go forward, new diagnostics, vaccines, what are the things we need to be focusing on now? So for Central New York, what I wish is 1, we have early diagnosis, and 2, we have good surveillance. So we heard yesterday about how early diagnosis for tick-borne disease, in particular Lyme disease, and I'm going to use kind of tick-borne disease and Lyme disease interchangeably here just because of the burden. We're mostly talking about Lyme, but for all of these, it's important. We know that if you can catch somebody when they have their EM rash, or if they don't have their erythema migrans rash, if they're in early disease, if you treat them then, that it can be more effective. They're less likely to go on to PTLD or later stage Lyme. It's simpler. You need just 1 drug that it can be oral, and it's for a shorter period of time. So we really need to catch people in this early window. And this is a figure that I borrowed from the Johns Hopkins website, showing, as we had seen yesterday, that about 80 to 90% of people will have near complete recovery if you catch them in the early phase. But the data shows that about 40% of people who are diagnosed with Lyme are diagnosed during disseminated or late disease. So we're missing a lot of people, which is a huge problem because this is a very widespread disease and infection. And there are many reasons why this is happening, and some of these are quite challenging. So we know that many people who present with this erythema multiforme rash, erythema migrans rash, can recall a tick bite. So most people who are coming in, it's not a clear slam dunk necessarily that this is a tick-borne disease presenting with this rash. We heard yesterday about how the rash can look quite different. Even if it's an erythema migrans rash, it's not always a classic bullseye. We heard yesterday from Dr. Embers that there may be some sex differences. So women may have a smaller rash than men that may not meet that 5 centimeter cutoff to raise your suspicion. We also heard about, certainly there's variability in your ability to detect by skin tone. It may present differently in darker versus lighter skinned individuals. And so this is also a barrier. So really this group of patients that is at highest risk of being missed, assuming you have an astute physician who has erythema migrans at the front of their brain, they know they live in a Lyme endemic area like here, it's this relatively large group of patients, about 20 to 30% of them, who may present with early Lyme, but have no rash at all. And so they have this very vague constellation of symptoms that is like hundreds of other things when you think about a differential diagnosis. Could be autoimmune disease, could be flu, could be COVID, could be anything else. And so this is really a problem. And as we heard yesterday, the antibody test will likely be negative when they're in early disease, or more likely to be negative. And again, the symptoms are nonspecific. I also want to raise, because this is a big priority, well, not just for our health department, for our community, but to be thinking about health equity in tick-borne diseases. And briefly, I won't go into this too much, but health equity means that everybody has the same opportunity to experience good health. And the way you get from A to B, the way you get to good health is going to look different for different people because there are different barriers. And we know in our area that there are unequal barriers to access to being evaluated by a clinician, to getting tested, and to getting treatment. We know that people are having a hard time getting primary care physicians, full stop. They have a hard time getting timely appointments. A lot of people don't have cars. So this is a major thing that we need to have in the front of our brain in terms of thinking about improving the health of our community, is that not all of us have ready access to timely diagnosis. The other thing that stood out to me is a need for provider education. So we heard a bit yesterday about the differences between the surveillance definitions, which are not optimal or well-defined for clinical care, versus the clinical definitions, which themselves are perhaps not well attuned to timely diagnosis and appropriate care. So there need to be improvements in that. And this figure was really impactful for me. This was for the Tick-Borne Disease Working Group who presented to Congress in 2022. And they solicited feedback from Americans about what their perceptions and experiences were with respect to tick-borne disease. And then they grouped them by theme as well as disease entity. And the common themes that came up, they got over 2,000 responses, were misdiagnosis, disregard, and delayed diagnosis. And so there is widespread experience of people not feeling like they're heard, but not even feeling like there was lots of really impactful quotes, particularly with respect to alpha-gal, where people don't understand it. They don't understand the impacts. They don't know how to support people. And of course, we know that this is an issue with Lyme disease as well. So we all need to do better. There's a huge space for clinical training and education, but there's also just more space for empathy and listening. This cut off a little bit, but this is just to highlight, this is an algorithm that was in emerging infectious diseases from the CDC about how to diagnose early Lyme disease. And the things I want to highlight from this is they require surveillance, and very good surveillance to actually know what you're doing. So they require you to know if Lyme disease is in your area and what else is in your area so that you know what your differential diagnosis is. They need information that tells you where Lyme disease in this case is distributed. So is it found in this area? Are there gaps in our surveillance? Absolutely. And you also need to know the seasonality of the disease. Are we in Lyme disease transmission season yet? And all of this requires not just robust surveillance systems, but for clinicians to be educated and aware of trends in surveillance. So this seems like, I'm not a Lyme clinician, but this seems like the traditional algorithm, but there are some assumptions here that might be problematic. And I wanted to highlight a local resource that has been very impactful and to me is exactly the kind of data that we need. So we need intensified tick-borne disease surveillance locally so that we can counsel patients correctly. What's out there? What do you look for? How do you avoid it? And so we can counsel clinicians. What is the amount of co-infection? What is the burden of disease in infected ticks? And this is data from Dr. Thangamani and his group's lab in the tick map, which is amazingly robust surveillance. And here it's shown at the county level, but it's also available for folks like potentially the local health department to the zip code level or census tract level as well. And New York State Department of Health does a fantastic job in their tick surveillance in terms of the breadth of the counties they need to cover longitudinally. But there's nothing like this in terms of local surveillance. So for example, in Onondaga County, I believe that it's over 3,000 ticks that have been tested to date. And they give rise to incredibly powerful information, including how many pathogens test positive for at least one pathogen. What is that pathogen? This is also from a publication from this group. So it can tell us what is present and where is it present within our county, for example, or central New York. It can tell us what are co-infection rates, which is incredibly, incredibly important as a physician who sees patients who may or may not have Lyme disease, to have in your mind, there's a pretty good chance they may not just have Lyme. They may also have Babesia. They may also have anaplasmosis. That is so, so important. And these kind of data support that improved clinical care of patients. And this table here is showing from their surveillance, from the ticks that were sent in through citizen science. Did we talk about what citizen science is yesterday? Okay, briefly, let me see how I'm doing for time. I'm almost finished anyway. But what they've done is, and this is an improvement over what is typically done with tick surveillance, which involves dragging, trying to identify ticks, going out to certain places where you may have, by nature of how it's typically done, incomplete coverage of an area. It'd be cross-sectional in nature because you're going out at certain times. In this case, people are finding ticks on their person or on their kids or on their pets and mailing them in with information about where were you when you were exposed? Where was it found on your body, or was it found on your pet? And then it's tested. So it gives us this remarkably granular, powerful information. And also tells us, for example, in our county, what proportion of ticks are infected with 1, 2, 3, or 4, in some cases, pathogens. It's also important, as I mentioned, a lot of tick surveillance is cross-sectional. So you go out one time and you look and see what's there, which is still valuable. But this type of surveillance can tell you throughout the year, what are the periods that are highest risk? For example, this is Babesia, looking at April through December, I believe is the last column, and showing you what months is our highest risk. So it's this longitudinal surveillance that is incredibly powerful. And again, maybe subject to change with climate change. It can also tell you important information about local tick-borne disease ecology. So here we're looking at different types of ticks that were sent in and identified, and then where they were found and who had they fed upon. So lots of humans, but also horses, goats, deer, dogs, cats, and then other types of animals. So just really powerful, powerful data. And it is my sincere hope, and the county is working fervently to try to support the continuance of this type of platform, because this is a threat that is going to continue to evolve in our area and is currently pressing and under addressed. And I think that is my last slide.
There are a few minutes for questions if you have any for Dr. Anderson before we move on to our patient care. That is the presentation. Q for the A, and A for the Q. Anybody? Now's your chance. Yes, Doctor.
Coming your way.
I'm curious about the Babesia being diagnosed more in the fall. Can you tell me more about that? I mean, Lyme disease more is an early summer thing. Are adult ticks transmitting it better, or is this, I'm not.
Do you mind if I phone a friend? And pass the mic to Dr. Thangamani, who generated those data? He'll speak with more authority and accuracy.
Well, it's primarily because adult ticks are easily noticeable by the people, so they actually pick it the nymphal and larval ticks are, it's the size of poppy seed, so it's difficult to actually identify by the, I would say, general public. But in addition to that, adults have 2 chances of getting infected, right? The larvae could feed on a bacteremic animal or parasitic animal here, and also the nymph can feed on parasitic animals. So there are 2 options or 2 ways that the adult ticks can be infected. So the chance of an adult tick being positive for babesia is very high. And it kind of correlates with the human behavior of identifying an adult tick on their body.
I also wonder if that matches the human clinical data diagnosis. And I was talking to Rob, I mean, thinking about babesia, your first go-to on a black-legged tick is to treat for Lyme, right? And then if a patient doesn't get better, maybe your differential switches to, oh, is it a co-infection with babesia, which is not, treated with doxycycline. You need to actually introduce antiprotozoal. So that's an interesting thought there for the physicians in the room.
Thank you, Dr. Anderson, for a fabulous presentation. I feel very good about your understanding of the severity of this disease for Onondaga County. And I wonder what you can say about other health commissioners of other counties in central New York coming on board to all work together to bring this under better control. Yeah,
So I will say, I can't speak much for other counties and commissioners, but my perspective is a lot of this work has been done at the New York State level, at least in terms of the surveillance, which makes a lot of sense. But I think that we need to be doing more locally in terms of our engagement and advocacy. We've benefited here from 2 things. Dr. Thangamani's surveillance and having Dr. Ledette and others who are so active in this field, having the clinical expertise that we have here, as well as the CNY Lyme Alliance. And so it really helps bring things to the forefront. And I am hoping that there is more space for engagement and advocacy. And it has begun with actually, for example, engaging them around the tick surveillance platform potentially.
Anybody else? Dr. Anderson?